morning, ladies and gentlemen of the press. My name is Dr. Brian Lishenga. I am the chairman of the Rural Private Hospitals Association. I am also a hospital owner in the country, based in Nakuru County. With me are my colleagues, board members of the Rural Private Hospitals Association. I can introduce them. We have on my far right Carol Mwikali, who is the CEO of the Rural Private Hospitals Association. Next to her is Pacifica Omwambia, who is treasurer for the deputy treasurer for the association. Immediately on my right is Joseph Kariuki. Joseph Kariuki is also a hospital owner and vice chairman of the Rural Private Hospitals Association. He has a facility in Kajiado County. I failed to mention Pacifica is a facility owner in Kibra in Nairobi. On my right, we have Dr. David Musita. Dr. David Musita is the treasurer of the Rural Private Hospitals Association. He is also a facility owner based in Kajiado County as well, specifically in Kitengela. Two of our board members were not able. In terms of membership, the single largest private hospitals association in the country. We are present in 43 of the 47 counties. I think the only counties where we don't currently have a presence are Lamu, Turukana, Wajir, and Moyale. Those are the only places where we might not have a presence, but our presence is growing across the country. Today, as we speak, the association represents 253 healthcare providing facilities across the country. And we have a lot of strength. In some places we have a lot of membership. For instance, we have a high number of members in Nakuru County. We have a high number of members in Busia, in Kilifi, in Kirinyaga, Kajiado, Mombasa. Those are some of the counties where we draw the largest membership from. Now, the Rural Private Hospitals Association, our members, provide healthcare to about 74% of the rural population in this country. We are the primary source of care for most Kenyans who live in rural areas. As you know, you can recall from the census that came out last year, Kenya is still a largely rural country. And so if you look at the distribution of facilities, public facilities in rural areas are very few. And therefore, between ourselves and the faith-based facilities, we are the ones that are providing care in these areas. Now, our concern is coming from the handling of the healthcare system since the emergence of COVID-19, when the first case was reported in February, I think 12th of February, and eventually when a lockdown was imposed about a month later. One of the main challenges that we have faced as providers serving the lower tier of this country, the rural areas, and even where we are present in places like Nairobi, we are serving the slum areas. The challenge has been the total neglect of healthcare facilities that serve in those areas. There's been a lot of allocation of funds, resources, to the fight against COVID. What we have experienced is a very skewed deployment of these resources. And what we mean by that is there has been concentration of these resources in, number one, public facilities, and those public facilities are the large ones. So we are talking about those ones which are present in big areas. So this situation is making it very difficult for our providers. As you are aware now, COVID-19 is in what we are calling the community spread phase. The number of cases in the counties are rising. We are worried about the preparedness of the counties. The expectation is that the peak in numbers will happen somewhere in September, October, and we think that this peak will be especially felt within the rural areas. We are not ready. As healthcare providers, we can guarantee that we are not ready. The country is not ready to handle these numbers in rural areas. There has been no meaningful attempt to incorporate rural private hospitals, rural faith-based hospitals into the fight against COVID. When we talk about training, when we talk about allocation of PPEs, it has been a complete neglect of those areas. Now, part of this has been compounded by the fact that our facilities do the largest number of service provision to NHIF members. If you think about rural Kenya, the people in rural Kenya, either they are paying out of their pocket, or if they have an insurance, that insurance is the National Hospital Insurance Fund. Now, ever since the lockdown was put in effect, the National Hospital Insurance Fund has actually been on the going down and down in terms of service provision. When the lockdown happened and people started working from home, what we saw is a drop in the processing of claims. So since March, processing of claims has literally ground to a halt at the National Hospital Insurance Fund. You remember there was a directive that all elective procedures, elective surgical procedures be postponed, because they were now, all resources were being dedicated to the COVID emergency. But the effect of that, the effect of postponing all the elective procedures, is that we have hundreds, or if possible even thousands of Kenyans who needed emergency surgery, who needed emergency procedures, that have been put on waiting lists. We do not have, up to this time, we have very slow approval processes for a patient who requires surgery. If you have an elderly woman somewhere in Busia, somewhere in Kakamega today, who needs to have a tumor resected, unless she is in an emergency situation and she's dying, the pre-authorization processes have literally ground to a standstill. When we come to the issue of payments hospitals from the National Hospital Insurance Fund, what we have had since March is very erratic payments. In terms of even the amounts that are being paid, very minimal amounts being paid. Now, the net effect of that is healthcare facilities are not able to respond at the worst time in our modern history. If you are fighting against disease and you're fighting against pandemic, and both your hands are tied at the back because you don't have resources, the net effect, and we are worried, especially now that we go into the peak of this fight, we are worried that when it happens, the facilities will not have resources. When it comes to the issue of outpatient care, I want to mention this very clearly, what we call capitation. The NHIF works on a model where a person, you select a hospital and that hospital becomes your hospital for care. Now, you have seen this, I think, in the media readings, that even the NHIF itself has reported that since June this year, the number of subscribers for outpatient care has fallen by 77%. So this is our concern. Look, if the NHIF has before June this year, 8.2 million members, Kenyans, depending on NHIF outpatient care, that number falling down by 77%. The situation where we are in is we are talking about possibly 5.6 to almost 6 million Kenyans today who cannot be able to access outpatient care when they need it. Now, that is on one hand. So if you're going to have community spread of COVID, and these patients cannot be able to access care because they are not attached to any facility, what do you expect? They will probably not seek care, and what will we have? A lot of people dying at home or coming into hospitals very late at the end of the day. So that's one side of the coin. The other side of the coin, when subscribers for NHIF fall by 77%, has a direct effect on resources available for healthcare providers to pay their staff, to pay their suppliers, to keep the hospitals open. So we are in a situation where, on one hand, Kenyans cannot access the hospitals because NHIF went into an ICT reform process, which we welcomed, and we told them very early that we welcome these ICT reforms to weed out fraud. But we also advised the NHIF that it must be done very well. Unfortunately, this did not happen. And the result of that is 77% of Kenyans who rely on the NHIF now can't access. Okay, so the ICT reform, well-meaning, a lot of money spent on it. We are aware that the NHIF spent almost 300 million shillings to buy what they are calling the e-claim system, which was supposed to expedite the process of claim approval. But as you know, in August last year, that system collapsed. The system for e-claims, where they spend a lot of money, collapsed. So what do we have? We have a situation where, number one, NHIF has reverted back to manual processing of claims, paperwork. Now, if they are doing paperwork and you have COVID situation where you are limiting the number of people available in a workspace, That means that the paperwork is not going to move. Number two, there were claims which we submitted through the e-claim system. I think in our estimate right now, about 5.7 billion shillings, which have been submitted, valid claims. Those claims since last year in August are just in suspension. We have no idea what is going to happen to the e-claim system. We think that if contributors' money, because this 300 million that was spent on e-claims is money from contributors. The NHIF is non-profit. This is money that contributors pay 500 shillings, 700 shillings. It was spent on purchasing an e-claim system. That money needs to have a return for the beneficiaries. The other issue I would like to address is the issue of accreditation of healthcare facilities. Now, you are aware that at this point we need more hospitals, we need more healthcare providers. Since the new Health Act came into effect and there were changes in the structure of accrediting facilities, we have had a very sluggish process of approval of new facilities. As we are talking right now, over 3,000 facilities in Kenya are waiting to be onboarded. Last month only, out of over 3,000 facilities, the NHIF board was only able to process 176. Now we are talking about a very severe decrease in work rate, and we are really concerned because this issue, no matter how many times we raise it with the NHIF CEO, with the NHIF management, this is an NHIF board issue. Facilities are approved by the NHIF board. We are concerned this work rate by the NHIF board at a point where Kenya needs more healthcare facilities. This is alarming. We have members who have been inspected, they have been approved, they have been issued with the inspection certificates, they have gone through the entire process of the Ministry of Health. The paperwork is at the NHIF, but for the last 2 years, the board has not been able to actually move facilities through the process. Now, what some of the things we are hearing is there are people going out of their way even to try and induce board members to have their facilities accredited. This is not the situation. Healthcare is a public need. Kenya does not even have enough health facilities. If you have Kenyans who have invested in healthcare, and it's not even only private people, even public hospitals are waiting for accreditation. So 3,000 facilities sitting on the back burner since 2017. We feel that this situation is unacceptable. And our call to the NHIF board, expedite this process. There is no reason why we should have no healthcare facilities. The healthcare facilities are there, they are equipped. We have Kenyans who are trained as nurses, clinical officers, medical records officers, doctors who don't have jobs. And the reason they don't have jobs is that healthcare facilities are not open. Why are they not open? The board is not pushing through these facilities to get open. So we are asking that this situation be sorted out. We are appealing. We have talked to the NHIF management. We don't seem to be getting headway. Now we are appealing directly to the people's representatives, to the National Assembly, the Health Committee, to the Senate, the Health Committee. We need to find out what exactly is the gridlock at the NHIF board. This is not the time where we should be having a decrease in health facilities. This is a time where we should be having more health facilities on, more health workers employed, more of them deployed to actually help the country. I mean, this is a very good question. Thank you for that question. So, I mean, this is a net effect. First of all, one of the things that has happened since the beginning of this year, and we have the statistics from our members, almost all our members have laid down somewhere between 40 to 50% of staff. At my own hospital, which I run, in May this year, I had 46 Kenyans on payroll, working in different positions. As we talk today, I have only 23 members of staff. So you can look at, in my case, I am looking at a drop of somewhere between 50 to 55% in my staff numbers. So these are Kenyans who don't have jobs right now. They are healthcare workers who are out there. This situation is the same across the country. Whether you're talking about Busia, you're talking about Mombasa, Kilifi, these are places where we are having rapid increase in COVID numbers. These are places where the usual diseases have been neglected because the focus, maybe rightly, has gone to COVID. But what about the patient who has a tumor to be resected? So cut down the healthcare personnel, we are not able to pay our suppliers. So this is net effect. The pharmaceutical industry is suffering. The medical equipment industry is suffering. the human resources industry for healthcare is suffering at the time when we expect that if there was a stimulus package, that stimulus package should actually have been largely focused on healthcare, so that we hire more health workers, pharmaceutical companies have enough resources to buy drugs, medical equipment companies can bring in ventilators. But if you're holding up 5.7 billion Kenya shillings in money that is valid claims, obviously you will expect that the healthcare system will grind. So we are looking at it this way. We look at there's money going to a hospital X, big public hospital, hospital Y, big public hospitals, but the forgotten story here is that below that, where we are talking level 4 facilities, level 3 facilities, level 2 facilities, your dispensary at home, there is no cash flow. Supplies have gone down, healthcare workers have been laid off, pharmaceutical companies are struggling, and now, as I said earlier, we are going into the stage of community spread of COVID. Now, we don't expect that the country will be ready. The little resources we have will be stretched to the maximum. Okay, so if we can estimate, yes, over 250 facilities. On the average, those facilities are holding about 40 workers. These are 10,000 Kenyan workers. So you can do the math. So maybe somewhere between 4,000 to 5,000 healthcare workers who should be deployed right now are out of the job market. Now, the economic impact of that, one healthcare worker maybe is depended upon by 3 or 4 people. So if you do the math, this is a large number of Kenyans. And extrapolate that to the pharmaceutical industry. If we are not paying them, they are probably laying off people. The medical equipment industry, if we are not paying them, they are also laying off people. Or people are redundant, people are half salary, a third salary. So I think the net economic effect is more, it's big. It's really big.
Kufanya mambo mengi kama kulipa mishahara, kulipa rent za hospitali zetu, pia kununua madawa na hasa PPE ambayo zimekuwa ghali sana wakati huu. Tunahitaji pesa za kununua PPEs kwa sababu kama hospitali ya kibinafsi hatupati hizi misaada kutoka kwa serikali, na tunatafutana nazo tuweze kununua. Kuna mashini nyingi ambazo zinahitajika wakati huu, kama vile mwenzangu alisema, ventilators na patient monitors na mambo mengi ambazo tunahitaji, ambazo gharama yake iko juu sana. Na kama hatupati pesa hizi kutoka NHIF, ambayo ndio asilimia karibu 80 ama 90 ya wagonjwa ambao tunaona ni wagonjwa ambao wanakuja na kadi zao za NHIF. Kwa hivyo pesa nyingi zimeweza kuzuiliwa pale, na tunaomba kupitia idara tofauti za serikali waweze kuangalia vile watatusaidia hapa. Hivi majuzi pia tumeweza kusikia kwamba waziri wa elimu amesema serikali inatoa kama bilioni 7 hivi kusaidia shule ambazo ni za private schools, kuwapatia concessionary loans. Tunauliza serikali pia iweze kuconsider private hospitals, hasa zile ambazo ziko mashinani, rural private hospitals, pia zipewe concessionary loans ili pia ziweze kujimudu na kuweze kusaidia wananchi wa Kenya, hasa wakati huu wa janga. Kwa hivyo tunauliza mambo haya yaangaliwe sana, na pia tunauliza kamati ya afya katika Senate na katika National Assembly wachukue jambo hili kama jambo la dharura, ili tuweze kushughulikia wananchi wa Kenya kwa haraka na kwa njia inayofaa. Asanteni sana na Mungu awabariki. Wakati leo tuna wazungumzia kuhusu hali iliyoko katika mahospitali zetu, ambapo tumepata kuwa na shida sana, hasa upande wa kifedha, na tunatarajia tumekuwa na matarajio mengi kutoka kwa claims ambazo tumeweka kupitia NHIF na ambazo hazijakuwa zikikuja kwa njia inayostahili. Kama mnavyojua, wakati huu tuko katika janga la COVID-19 na hospitali zetu zinahitaji sana pesa kwa wingi ambazo tutaweza kutumia ili tuendelee kutoa huduma inayofaa katika raia wa nchi yetu tukufu. Na pia ni vizuri kuweza kujua kwamba pesa ambazo zinadaiwa na mahospitali ya Rural Private Hospitals Association ni karibu bilioni 5.7 ambazo bado ziko kule, claims zinalala kule, hazifanyiwi kazi na hospitali zinahitaji pesa hii. Na kwa sababu ya hayo tumeweza kuona hospitali zikifuta watu kazi, zikiachisha watu kazi, madaktari, clinicians, nurses na watu wengi katika hospitali. Tukiangalia takrimu ambazo tuko nazo kwa sasa, tunaona kwamba kati ya 40% na 50% ya wafanyikazi wetu wameweza kuachishwa kazi kwa sababu ya janga hili na ukosefu wa pesa. Malalamishi yetu ni kwamba shirika la NHIF liweze kuinuka na kuharakisha utendakazi wao, kwa sababu tunaambiwa kwa sababu ya COVID-19 wameweza pia kupunguza nambari ya wafanyikazi ambao wanahitajika katika ofisi katika wakati mmoja, na hiyo imefanya kwamba claim processing iweze kuchelewa sana na kuleta shida katika hospitali zetu, hasa kule mashinani. Tuko na changamoto nyingi ambazo zinahitaji fedha hizi. Okay. Sababu ya NHIF kuchelewesha hizi pesa, kwanza kabisa ni mfumo wao mpya wa ICT ambao kwanza waliweza kuintroduce, na tuliukaribisha sana na tunaupenda kwa sababu inasaidia sana kwa kuavoid mambo mengi ambayo si ya hasa ya ukweli katika claim processing. Lakini unakuta kwamba katika mpango huo waliweza tena kusimamisha hiyo e-claim ambao walikuwa wameintroduce, na hiyo e-claim kutoka wakati kuisimamisha Agosti mwaka uliopita kufikia sasa kuna claims kama bilioni 5.7 ambazo zimefungiwa pale katika ile claim. Ziko genuine lakini haziwezi kuwa process kwa sababu zimefungiwa pale. So hapo kuna pesa mingi zimeachwa. Na pande hii ingine ni mambo ya capitation. Capitation ni zile pesa ambazo tunapewa kama hospitali kwa wale wananchi ambao wamechagua hospitali zetu kupata huduma. Tumeweza kuona tangu walete hii mpango yao ya ICT kuanzia mwezi wa Juni, reduction kutokana na figures ambazo zile wametupatia ni 77%. 77% reduction ya wale watu ambao wamechagua hospitali. Inamaanisha kwamba kutoka ile milioni 8.2 ambayo walikuwa nayo kabla wajaleta hii mfumo mwezi wa 6 mwaka huu, sasa kuna watu kama milioni 5 ambao bado hawana mahali ambapo wanaweza enda kwa hospitali, na hiyo ni tishio kwao na kwa hospitali pia. Tishio kwao kwa sababu kama hawana facility ambayo wamechagua hawezi kupata matibabu, na tishio upande mwingine kwa hospitali kwa sababu hizo pesa zao hazitapatiwa katika hospitali, na tusipopata pesa hizo zao inamaanisha hatuna pesa ya kuendeleza matibabu kwa wananchi wa Kenya. Hatuna pesa za kulipa wafanyikazi, za kulipa rent, za kulipa suppliers wetu, kununua madawa na pia kuendeleza hospitali hasa wakati huu wa janga la corona. Hayo ndio malilio yetu. Kwa kweli tunakaribisha sana huo mfumo wa ICT kwa sababu kulingana na vile tunaelewa mfumo wa ICT kwanza unarahisisha kazi. Mfumo wa ICT unaondoa visa vya wizi na udanganyaji mwingi na inafanya kazi kuwa rahisi. Kwa hivyo sisi kama wana hospitali tunakaribisha sana huo mpango. Shida iliyokuwa nayo ni jinsi ambayo imekuwa implemented, vile ambayo imekuwa launched. Imeletwa katika njia ambayo inaleta madhara mengi kuliko faida, kwa sababu kama hii mfumo wa capitation walikuwa na members, NHIF ilikuwa na members karibu milioni 8.6, na walipo introduce hii ICT system ikawa wame throw out about 5 million members. Wenyewe katika takrimu zao ndio wamesema wame lose 77%. Hiyo ni kumaanisha hii ICT mfumo wa ICT haija toa suluhu mzuri ama ijaleta sababu nzuri ambazo inastahili ilete na badala yake imeleta shida. Kwa hivyo tungependa kuwauliza kama tunaweza kuwa in a consultation, tuongee pamoja, tuelezane ni vipi tunaweza kusaidiana tukaleta hawa ambao wanapotea katika hesabu zao, ili wananchi, serikali pamoja na sisi tuweze kufaidika katika shughuli hii yote.
Mwisho kabisa,
kuna hospitali zaidi ya 3,000 ambazo tayari zimeangaliwa na serikali na kuthibitishwa kwamba ziko bora kuweza kupeana huduma, na katika hospitali hizi ni 176 peke yake ambaye bodi ya NHIF imeweza kuzipatia accreditation. Na hiyo ni kumaanisha kwamba hiyo process imekuwa slow sana, imekuwa polepole sana, hasa wakati huu wa janga la corona. Tungeomba bodi ya NHIF ifanye haraka iwezekanavyo kuleta hospitali hizi zingine katika nafasi ya kupeana huduma, ili tuweze kusaidiana kupatia wananchi wa Kenya huduma ya afya inayohitajika sana sana, hasa miezi hii 2-3 inayokuja. Asante.